I guess it is my pleasure now to introduce the 2021 Clinical Care Symposium. And please take it away, guys.
Thank you, Annette. My name is Nicole Ulrich, and I'm a neurologist and NF specialist at Boston Children's Hospital. And I have the pleasure of moderating the 2021 Clinical Care Symposium. This has been organized by the Clinical Care Advisory Board of the Children's Tumor Foundation. And we'll begin by introducing the CCAB US and CCAB Europe chairs, Dr. Scott Plotkin and Pierre Volkenstein. And then Dr. Plotkin will continue with discussion of the mission and objectives of the CCAB US.
Thank you. Good morning to everyone. Good afternoon, depending on where you are. My name is Scott Plotkin. I'm a neuro-oncologist at Mass General Hospital. It's a great pleasure to kick off this clinical care symposium along with my colleague, Dr. Pierre Volkenstein, to talk a little bit about the clinical care advisory boards, both in the United States and in Europe. Oops, thank you. Just a quick overview of the timing here. You can see the agenda for today. As I mentioned, we're going to quickly talk about the US and European CCABs. I'll give a short overview of some of the progress we've made in the past year in hopes of demystifying for everyone what the CCAB does and maybe to generate some interest in participating with these efforts. We're then going to have a talk on access to NF clinics and receipt of guideline concordant care. Then a talk about transition from pediatric to adult care. And finally, a discussion about patient access to novel NF treatments, much of this work being done by members of the CCAB. Finally, we'll have what I hope is one of the highlights of the meeting, as it is most years, a virtual case discussion, really highlighting the challenges we face taking care of patients with NF, but also the wonderful expertise that is available within our communities. Just in case you want to find out more about the CCAB, I wanted to make this clear. It's here on the webpage at Children's Tumor Foundation. If you go to the tab Who We Are, you'll find us there along with other groups that are working within CTF to improve NF clinical care. And really just to highlight here the members of this community, of this board, as well, which is on the left, all the clinicians. I won't read everybody's individual name, but I will say thank you to everybody who's working extremely hard on behalf of the group. And really put a shout out to our patient representatives, as you can see in the top right, Ellen Diaz, Rima Bogan, and Dale Berg. That really highlights our commitment to patient representation and making this a very patient-facing organization. And finally, really to highlight the people with whom this would not be possible, the CTF staff, including Pam Knight, Heather Radke, and Salvo La Rosa. So thank you very much for all that support. I wanted to just spend one slide talking about our priorities for 2021 and 2022. We have a retreat every year where we discuss some of these, and I'll just point out these are in no particular order. They just represent many of the topics that bubble to the top and we are trying to address, and I'll quickly run through them. We're very focused on developing educational programs for the revised diagnostic criteria. Early this year, Eric Legis and colleagues published these new NF1 and Legis syndrome diagnostic criteria. We hope to follow those with NF2 and schwannomatosis, and we know it's going to be important to educate ourselves about those. We also wanted to launch a virtual case conference, which is what we'll do today. You'll hear more about that. To develop and execute a study of COVID-19 outcomes in NF patients. Both, you'll hear about that from last year and from this year. To explore the possibility of developing an online program to create personalized care plans for patients and providers. You'll be hearing about more about that in the coming months and years. To identify facilitators and barriers to accessing new NF treatments by surveying clinicians and patients. To explore ways to expand access to NF care for adults, always a challenge for us. We're going to hear about that later in our program this morning. How to assess healthcare disparities within the NF community and to potentially work on minimizing those disparities. And to continue a project of identifying and adopting clinical care guidelines which we hope to do in collaboration with the EU team, the European team, as we think about global care for NF. Oops. Sorry, I'm having problems with the forwarding here. I might need a little bit of help. Thank you. And I'll hand it over now to Dr. Wolkenstein to talk about CCAB in Europe.
So thank you very much, Scott, for this very good summary of what you are doing, but you will complete in a few minutes. So I am Pierre Wolkenstein. I am a dermatologist and also oncologist. I am chairing the CCAB Europe. And as you see, we have a lot of members and that are covering all the fields of NF, NF1, NF2, schwannomatosis. And thanks to your suggestion, we include also 3 representatives from the lay groups and from patients. So I think I can move the slide. Yes, so I think that the CCAB US is existing for more than 10 years, so we can consider that it is, he is or she is a teenager. In CCAB Europe, we are a baby. And during this first year of life, this was a pandemic, and you see that in this map, the really dark green was the countries that were involved in the CCAB, so it was rather difficult. But now we are removing masks, and it's time to go and work. So we will take exactly the same role as in US. We will try to participate with energy to the expansion of the NF registry. We will also to strengthen the European NF clinic network, and of course, to live in a globalized discovery funding, but also in a global science. So if we are probably 2 brothers, I would say, CCAB Europe and CCAB US, we have a cross-fertilization, as Scott is involved in the CCAB Europe and vice versa. So again, I thank the suggestion to engage patients in the CCAB Europe. And you see that we are participating also to an international consortium devoted to optic pathway glioma care, but also to a European project that will develop the so disruptive platform trials. So for us, it was really an issue with the COVID concern, I would say, or the COVID storm. And we focus this year to complete continuous medical education devoted to neurofibromatosis with 3 targets: physician, paramedical staff, psychologists, neuropsychology, social workers, nurses, and lay groups, of course, and patients. We will develop virtual formats, very short, 20 minutes with 10 minutes of discussion in a platform. And it's a kind of model that we quote from CCAB US with the new experience of virtual cases. We would like also to develop some disruptive encounters, meet the experts. For example, a topic could be MEK inhibitors in NF1 or controversy, meningioma, when to treat, when to abstain. So I would like to end this talk by a great thank to Arnett and to Marco Nievo, who participated to the setup of this new committee in Europe, and also to Ross Furner, that is co-chairing with me the CCAB Europe, and all the members, and specifically the representative of patients. Thank you very much.
Thank you, Dr. Wolkenstein. I'm going to take back the reins now and then provide a little bit more insight into the some of the work of the CCAB again to highlight for people what we're trying to accomplish and hopefully to stimulate interest in participating. And I'm going to point to these 6 highlights: how we support and manage the NF Clinic Network, the work that's been done on the virtual case conferences, including the one you'll hear about today, work on using MEK inhibitors for NF1 patients, studies on barriers to access to new treatments, our interest in understanding the implications of COVID-19 and telehealth, and then working on clinical care guidelines. So if somebody could advance me, I'm sorry that I don't. Oh, I do have access now. Okay. So one of the key functions, apologies, I need to go back one. Let me try one more time. Okay. One of the key functions of the CCAB is to help manage the NF Clinic Network, which is a collection of clinics across the United States, and we hope beyond in the days to come, that can document certain expertise in caring for NF patients. And the goal is not just documentation, but also to encourage clinics and help them provide mentorship. And what you can see here is this process, which has been around for more than a decade, requires continuous tweaking. In 2020, a lot of tweaking was done to update this process, and we hope that makes it a better process for clinics and also for patients who are accessing care. Importantly, 9 new clinics were added to the NF Clinic Network. You can see in which states they are. And importantly, that includes at least 2 states, that did not have a dedicated NF clinic in the past. So really trying to expand access in the United States for individuals. 2 clinics were deferred, and it's important to understand that we don't look at that as just a rejection as much as it is an opportunity to help clinics that are developing gain expertise in providing multidisciplinary NF care. And you can see now that a total of 66 clinics are part of the NF Clinic Network. One of the big plans for this year is to expand the NF Clinic Network into Canada. That's ongoing, and Dr. Jan Friedman has been a willing participant. We thank him for his work in this subcommittee to help screen clinics in Canada. And of course, I just want to point out the strong leadership from Heather Radke, Laura Klesse, and Caleb Yohe in making this work happen, among many other individuals. Virtual case conferences really represent one of the primary teaching tools we believe for our community. It's something that's always been very popular, and Dr. Volkenstein also referred to for the CCAB Europe initiative. And in addition to providing insight into complex NF cases, it also provides an opportunity to build community. So this has been a big part of our work this year. We have Dr. Pamela Trepane to thank for a lot of this work. And you can see the outline of these virtual case conferences that last 60 minutes with didactics, case presentation, and an expert panel. You can see the list of sessions below. And if you look to the very bottom, you'll see June says CTF meeting. And I hope you'll be able to attend at 11 a.m. Eastern time in the US to join that conference and hear how it works. And we hope this is a big success. Please give us your feedback on how you think it's going. With the approval in the United States of selumetinib for NF1-related plexiform neurofibroma in April 2020, our focus has been on helping individuals prescribe MEK inhibitors for appropriate patients. And one of the main things that we believe needs to be done is education about managing side effects. And to that end, the team led by Laura Klesse and Caleb Yohe pulled together some guidelines for using MEK inhibitors in NF1 patients with a focus on toxicities. And that work was published in The Oncologist earlier this year with a companion page for patients published by the Children's Tumor Foundation, which we hope will be available and helpful for people who are prescribing these medications. We hope selumetinib is the first of many new treatments for NF patients, NF1, NF2, and schwannomatosis. And to that end, it's important for us to understand what barriers exist to access these treatments. And we recognize that the barriers can be on the patient side and on the provider side. And so our goal has been to understand those barriers now as this new era is opening. And to that end, the team has now surveyed all the members of the NF Clinic Network in work led by, again, Heather Radke, Pam Knight, and Laura Klesse. And you're going to hear the results of that in just a few minutes when Dr. Klesse will present some of that interesting and important work. As Dr. Volgenstein mentioned, COVID-19, 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 that's where we've been for 15 months. And our focus has been first to understand the impact on our community. And this work led by Dr. Bonnie Klein-Tasman and Dr. Vanessa Merker, along with Heather Radke, who seems to do everything. We looked at how the pandemic has changed care delivery in the United States. And this work was recently published, as you can see here, on that impact on the NF community. We hope that provides some insight into how our field has changed so rapidly. And I would just point out how flexible our providers have been in the US and I think also worldwide. We're following up that study and work that was really supported by Alan Diaz, one of our patient representatives, and we have him to thank for really pushing the CCAB to take the next step in work led by Dr. Jayshu Blakely and Dr. Janeta Banerjee, using a federal resource, the National COVID Cohort Collaborative, the N3C, to really dig deep and to understand patient outcomes, those who have NF compared to those who don't. And I think you'll be very interested to see those results, which are being presented at this conference. So I think it's in poster format. But please look for that. But it might be a presentation, and I forgive me for that. But I hope you'll look at that important work, which has come along very nicely. Standardizing and improving clinical care really has been the goal of so many of us who want to make sure that we're giving patients the best care. And it has been a long road and will be a long road. It's something that I think the European and US CCABs are committed to, but this represents a long path along the way. And in the past year, we've been looking at this idea from two complementary ways. We're using surveys of clinicians to understand their agreement with published guidelines for NF care. And on the other hand, we're surveying patients to understand what kind of care they're receiving. And that gives us a view of what people support, what the clinicians support, and what the patients are actually receiving. The CCAB presented last year the results of the clinician survey. And in just a little while, Dr. Vanessa Merker will be presenting the results of the patient survey, which I think are quite informative and quite interesting and will lead to a lot of discussion. One of the core features, again, of the CCAB is to produce patient education resources. And I want to thank, again, Heather Radke, Dr. Tina Rosso, Dr. Nicole Ulrich for really leading this work. These are brochures available online. In 2020, 3 of these brochures were updated: plexiform neurofibroma, segmental NF, and genetic testing for NF. And you can see below the plan brochures, multiple are in works. This is also an area where, particularly if people who are interested in education would like to help out, we would love to get some additional help in writing and editing these brochures. And so when we think about the mission of the CCAB to improve clinical care, that work is manifested as the work on establishing guidelines and certifying NF clinic networks. We feel the role of the CCAB is also to research important topics to the larger community. And that work has been manifested in our work on COVID-19 and NF care, as well as patient access to new treatments. I didn't have time today to talk about identifying and funding the best clinical research, which is done through the Children's Tumor Foundation's Clinical Research Awards, that we try to identify that best science. And finally, educating patients and clinicians. We've been working on that, as I mentioned, through updating patient brochures, these virtual case conferences, and when it's relevant to publish review articles such as the one on MEC toxicity. So I hope this has given you a sense of what we're working on and how we think about our role. And we would love to get feedback from people along the way. And thank you for the opportunity to present on behalf of the CCAV on both sides of the Atlantic.
Thank you so much, Dr. Plotkin and Dr. Volkenstein. I have the opportunity to introduce our next speaker is Dr. Vanessa Merker from Massachusetts General Hospital in Boston, Massachusetts. She is going to speak to us on access to NF clinics and receipt of expert recommended NF care in the US. This is a follow-up to the publication of new guidelines for pediatric and adult care. Dr. Merker, please take it away.
Thank you so much for having me, Nikki. I'm so happy to be here. Just working on advancing my slides. I have no financial disclosures that are relevant to this presentation. As Nikki mentioned, I'm a health services researcher at MGH, and since this is a field that's a little bit newer to NF, I wanted to start out with a little bit of the background to orient us to our approach to studying access to care and care quality in NF. Many of you are probably familiar with this translational research spectrum. I like to think of it as a relay race. And if we're in the relay race, health services research is really picking up this baton here at the T2 to T3 translation, so that we can make sure that when we have new innovations, whether that be new drugs, new diagnostic criteria, or any new information about NF, making sure that really translates to everyday practice and to the larger population, so that we really are making public health more equitable and effective. So the goal of this project and all the work we do as health services researcher in NF is to ensure that all NF patients, no matter where they live or where they get their care, have access to really high quality medical services. So what do we know about this topic in the United States so far? A couple of years ago, we published a paper in BMC Health Services Research looking at the NF clinic network, which back in 2015 had 50 NF clinics, showing how fast it's been growing. But back then, when there were 50 NF clinics, we looked at the estimated population of people with NF in the US and found that only 13% were going to these 50 NFCN clinics. And when we looked at people who were enrolled in the NF patient registry, only 43% of people in the registry were also going to an NFCN clinic. We also looked at geographic access to care. And in this figure from our publication, the red dots on the map are NFCN clinics. The green dots are patients in the NF registry. And looking here at the median in the table here, that's the median driving distance to get to a clinic. And you can see that for people with NF2 and schwannomatosis, access is limited to getting to centers that do see a high number of NF2 and schwannomatosis patients. And care for adults is also limited in trying to get access to adult clinics. But the question that sort of remained after this work, which was done mostly on administrative data, is what would the patients say are their main barriers to attending NF clinics, and how can we then address those barriers? Switching gears a little bit to thinking about care quality, we do know that there are published guidelines and recommendations for the care of NF1 and NF2 and schwannomatosis, which hopefully can help standardize care and make sure everyone is getting the recommended basics. The two starred items here are guidelines that were recently published and endorsed by the AAP and ACMG respectively. We also have recommendations for care coming out of the UK for NF2 and schwannomatosis. This is not every guideline that's been published. I want to acknowledge there's been some more recent work, but the ones in this table form the basis of our patient survey that I'll be presenting today. And as Dr. Plotkin mentioned and Dr. Jordan presented last year at this meeting, we did survey NF clinicians in the US about how much they agreed with these guidelines. You can see some of the NF1 guidelines here on this slide, with the dark blue showing how many clinicians strongly agreed, and orange being how many agreed. And there are definitely multiple guidelines that have high agreement, and so I think are important to get into care. But the open question is, are NF patients actually receiving this in practice? So to answer both of these questions, we designed a survey of US-based NF patients or caregivers enrolled in the NF registry. We just fielded this survey last month to coincide with NF Awareness Month, and it was administered inside the NF registry's online platform, which is Open App. Because this was just 2 weeks ago that the survey closed, we're just going to present some of the descriptive and unadjusted statistics today to get a feel for the data. And over the coming months, we'll be doing some more sophisticated analyses, and we're looking forward to sharing that as they develop. So we had 392 people respond to our survey last month, which is 5% of everyone who was eligible and 15% of those who opened recruitment emails. Looking here to compare the eligible population to the respondents, we can see that in terms of gender, it was fairly well matched. We slightly overrepresent white non-Hispanic folks. In terms of adult versus pediatric, about half and half for NF1, and then most NF2 and all schwannomatosis patients were adults. Also, some information about our sample. This is a primarily English-speaking sample at home. And in terms of insurance, 62% had commercial insurance, by which I mean employer-sponsored health insurance, or if insurance that someone purchases on the exchange. And then 22% had government insurance, by which I mean Medicare, Medicaid, or both. We thought this might be relevant because for people outside of the US, government-sponsored health insurance usually pays less to providers, so not as many providers will take it, and it could be an access barrier. We also dug deeper into people's finances, knowing that this might be a barrier to care. The 5 categories here are income quintiles for the US general population. So this is household annual income, and in the underlying population, 20% of households are in each of these categories. So you can see from that data that we do slightly overrepresent, or significantly overrepresent, higher income households. However, I think it's interesting, even in this higher income skewing distribution, a number of people either delayed medical care or did not get medical care they needed because of cost in the past 12 months. 15% endorsed at least one of those 2 options. So as we think about care quality, of course, we have to think not just what tests are doctors recommending, but also what can people afford, unfortunately. So the first section of our survey focused on access to specialized NF clinics, and we use that term specialized NF clinics because it's mentioned in multiple guideline publications. Specifically, we asked patients if they had been seen at a specialized NF clinic within the last 3 years, and we said many specialized NF clinics have neurofibromatosis in their name, or they see many NF patients per year. So that's a little bit open to interpretation from the patients what that means. But just over half endorsed going to a specialized NF clinic in the past 3 years. And this was higher for people with NF2, lower for people with schwannomatosis. For the 37% of people who said they had not been to a specialized NF clinic, we did dig deeper and we asked them what their reasons for not attending a clinic were. We had 5 items that we had a priori thought might be important, and we asked them to rate whether this was a major problem, a minor problem, or not a problem for them. And you can see the biggest problem for people was not knowing that specialized NF clinics existed, followed by insurance coverage, and then followed by travel concerns. Although I think it's interesting, while not seeing the value in attending an NF clinic was the lowest rated quantitative item, we did have a free text box where people could add in additional barriers to attending clinics. And not seeing the value or need in attending was actually one of the most common free text item. This included 3 flavors. So the first being, I already have a doctor that I like who's not in an NF clinic, so I don't want to go. I think that doctor is good enough. The second kind was, I don't have a very severe case of NF, so I don't think I need to attend a specialized clinic. And the third being a little bit more vague of just, I'm not really sure what that kind of clinic could offer me. What would the benefit be? The additional free text comments largely recapitulated some of our existing items. And then there were a couple of comments about not knowing how to find a specialized NF clinic or where they were, having trouble making appointments at a specialty clinic, and never being referred by your PCP. Now, switching gears to some of the guideline recommended care. I won't show all of them in the interest of time, but I want to show at least a few highlights. First, we looked at annual monitoring for pediatric NF1 patients. So there's a number of services that are recommended that you do every year: recording height and weight, checking blood pressure, having an eye exam, asking about signs of puberty, doing a detailed skin exam, screening for scoliosis with an Adams forward bend test, and discussing developmental milestones and or school performance. And so looking in our sample of kids with NF1, you can see that about a fifth said they had not discussed signs of puberty or done a skin exam in the past year. A quarter had not been screened for scoliosis, and more than half said they had not discussed school performance or developmental milestones with their team. Not all of these guidelines are relevant for adults, obviously, but we did ask about 3 of these items that may be recommended for adults. The recommendations for adults are a little bit softer, kind of a recommendation more than a guideline, but you can see that the rates of adults getting these tests is significantly lower when compared to the pediatric cohort. I think signaling that for adults, it's a little bit harder to get good NF care. We also asked about some items that are not annual, but are just once ever information. So for instance, multiple guidelines suggest educating patients and families about MPNST signs and symptoms, including a risk of developing an MPNST. And what was kind of shocking to me was half of patients said that they had never discussed this with their NF team. I put the actual text of the survey questions here so you can see exactly what we asked participants. But I think this is definitely concerning that obviously we can't tell that the team never talked about it, but at least what are patients retaining from that conversation such that they can answer these questions, and maybe there's room to grow about education on MPNST risk. We also looked at some subpopulation specific guidelines, so guidelines for people with specific medical conditions or demographics. The one I wanted to highlight here was about breast cancer screening. Current NCCN guidelines recommend annual breast cancer screening starting at age 30, and there were 89 women with NF1 in that age group in our sample. In this group, a third had never discussed breast cancer screening with their NF team, and 42% had not gotten breast cancer screening in the past year, despite being in the eligible age group. Switching gears now to NF2 recommended care, we looked at 3 monitoring services that are recommended as kind of the basics of NF2 care. The first is an annual brain MRI, and everyone in our sample did have a brain tumor, so this is recommended every year. And you can see that 87.5% had gotten that brain MRI. Spine MRIs are recommended at 2 to 3 year intervals, unless you don't have any spine tumors. So in the 41 people who did have a spine tumor, 92.7% had gotten a spine MRI in the past 3 years. And then the final recommendation is for annual audiology with measurement of pure tone thresholds and word recognition scores. In the 40 people who had some usable hearing, 85% had that testing in the past year. The thing I think it's important to highlight is that the people who are non-concordant are not the same in each group. So actually 25% of our sample was not up to date on at least one of these 3 tests for the ones that they were eligible for. We did also ask schwannomatosis patients about MRIs and genetic testing, but because that number was so low in our sample, I'm not going to share it today. So for next steps, we're definitely going to dig more into these analyses. We want to leverage the very dense demographic and clinical data in the NF registry that we have both for our responders as well as non-responders, so that we can weight our analyses to adjust for non-response. And once we've done those weighted analyses, we're going to look for predictors of access to specialty clinics and receipt of expert recommended care. We'll be working with the CCAB to update and disseminate these guidelines to help standardize care. And the plan is to field this survey annually so that we can benchmark progress in improving NF care nationally. Some of these guideline efforts might include funding additional prospective studies to establish a research base for guidelines that are less agreed upon or have some less clarity, perhaps. Doing a Delphi approach involving not only clinicians, but patients and caregivers to get input on what metrics to prioritize and how to define these quality measures. And then to collaboratively work on implementation and addressing barriers to implementing this care within the NF Clinic network and beyond. I want to thank the CTF Clinical Care Advisory Board and especially Drs. Potkin and Jordan for their work on this project. I'd also like to thank the staff of the Children's Tumor Foundation, especially Pam Knight, who's the queen of the NF registry and helped us with the administration greatly. And of course, the participants in the NF registry for filling out these surveys. It really matters to us and helps us improve care. With that, I will finish up and take some questions.
I want to thank you so much for your talk, Dr. Merker. I want to make sure that folks in the audience know that they can ask questions of the speakers, so please feel free to do that, and I will relay those questions along. Dr. Merker, I have a few questions, and I know that the data is still coming in with regards to the survey. Did it seem surprising to you? I know it was to me that many pediatric and adult patients with neurofibromatosis type 1 were not getting a skin examination or even a developmental evaluation or assessment as part of their routine visit.
Yeah, I think one of the most important things will be to see how many of those people had gone to any care versus they went to an NF doctor visit and that person didn't do the skin exam or milestone, because we did ask these questions looking at just in the past year, have you had this? So, I mean, I think maybe that would be informative, is the large chunk of people who aren't getting this simply because they're not seeing anyone versus because they're going to see a doctor who doesn't ask about it. And obviously there's two different paths then of what we have to improve depending on that. So I think it's a great point to look at in the analysis.
Yeah, I guess the follow-up to that is whether or not patients who go to an NF specialty clinic are more likely to receive guideline-related care versus those that do not. And how can we improve access to that now that we know that there's really a deficiency in terms of perceived access or access?
Absolutely.
Any of the panelists have any additional questions for Dr. Merker? Excellent. Thank you so much for sharing those results, and we look forward to hearing about them as they unfold.
Thank you so much.
The next speakers will be Drs. Tina Rosser and David Viscachel from the Children's Hospital Los Angeles and University of Utah, respectively. And they will present to us today on healthcare transition in the neurofibromatosis.
Yes, good morning, everybody. Dave Viscachel and I are going to share this topic today and present on behalf of the CTF's Clinical Care Advisory Board. Let me see if I don't appear to have control over my slides. There we go. Okay. So when thinking of excellence in NF clinical care, we know this group in particular that the neurophromatosis are a complex set of genetic disorders. There's a variety of potential complications that can develop in numerous organ systems over the lifespan in any particular individual, and that coordinating multidisciplinary care is key to having excellent medical care and good outcome in these groups. The CTF and CCAB strive to provide evidence-based guidance, education, and support for the clinical care of children, adolescents, and adults with NF1, NF2, and schwannomatosis. And we share the goal of providing the best possible quality of life in this patient population across the lifetime. Oops. We know that healthcare transition plays a critical role in ensuring continuity of care in the neurofibromatoses, and that these disorders have multi-system involvement, high clinical variability, and age-dependent manifestations. By healthcare transition, we mean the process of moving from a child and family-centered model of healthcare into an adult and patient-centered model of healthcare. And this involves a lot of planning, transfer, and integration into an adult healthcare center model. There's been, over the last decade or so, a nationwide movement within the field of pediatrics to recognize the importance of a structured transition of clinical care from a team of pediatric providers to a team of adult providers. And we recognize that pediatric providers have the responsibility to help transition these patients and facilitate this transition. There are three major professional organizations, including the American Academy of Pediatrics, American Academy of Family Physicians, and American College of Physicians, that recommend that all youth receive pediatric to adult healthcare transition services. And we know that there's also broad support from additional subspecialty organizations, in particular within the fields of medical genetics and neurology, since these specialties require such complicated care for our patient populations. Again, looking at the excellence in providing clinical care, we know that the best clinical care is provided with clinicians with experience and knowledge of the potential NF complications, as well as the management of these complications. This can occur in a dedicated NF clinic, as you've heard about the clinic network, or it can reside within centers or with clinicians who've developed an expertise outside of a formal NF clinic setting. Children's hospitals have long been the center of coordinated care for children and adolescents with complex genetic disorders, and this can make it very difficult to transition into an adult healthcare model, which is substantially different. But again, this requires a lot of collaboration, ideally between pediatric and adult providers, to ease this transition process. You can see from these tables here that there are significant differences between the pediatric and adult healthcare models. In the pediatric world, there's a lot of support. Healthcare is really driven by the provider and the parent. There's a lot of control over management of medical problems. Care is often comprehensive and provided in multidisciplinary clinics. There's often the one-stop shopping within a children's hospital where all care can occur under one roof, which facilitates care. There's often significant case management and social work support, and families generally feel fairly supported through this process. As patients transition into the adult healthcare model, there's a lot less support. The patient ultimately needs to become responsible and independent in managing their medical problems. Sometimes this requires bringing together multiple providers to care for separate medical issues, and this can be a challenge, particularly if they're in different institutions and all the care can occur under one roof. There's a lot less social work and case management support for patients, and ultimately, each individual patient needs to learn to be very proactive in how they get services and coordinate their care. But again, this can be hard, particularly if there's not adequate support during the transition process. This slide summarizes the various subspecialty services that an individual with NF1, NF2, and schwannomatosis may require. You can see that they're highly variable, and we know that each individual patient may have very individual and unique needs. The challenges in transitioning can be particularly difficult with NF1. This slide highlights how NF1 often presents at birth, and the manifestations can really change over the course of the lifetime. Handoffs between key providers really depend on each individual manifestation, institutional guidelines, insurance provider, and subspecialist training and experience. And at various points over the lifetime, there may need to be a balance between surveillance of certain manifestations versus active management of these. What a child and infant need early on in life may be very different than what adults need later in life, when problems such as malignant peripheral nerve sheath tumors, breast cancers, and other problems can appear. There are several significant important components of transition of care. It's important that transition begins in the early to mid-teens, and we know that it can continue way past 18 to 21 years of age. it's very important to educate families and patients on the need for these young adults to take over independent management of their medical care. Some of the components include comprehension of the underlying NF disorder. What form do I have? What are my particular medical problems? Patients need to understand their medications and why they take them. They need to have a good understanding of their past medical history. Again, what are their problems? What surgeries have they had? Which doctors do they see? And there's a big need to just understand the basics and logistics of obtaining medical care. How do I make an appointment? How do I change an appointment? How do I arrange transportation to get to my appointments? It's important to track health issues. Again, what are my medical problems? How do I obtain medical records? How do I help my providers, again, which may be at different institutions, communicate with each other to coordinate my care? How do I talk to providers? And this can be both in the clinic as well as outside the clinic once you go home. What if you have a problem or a question? How do you get in touch with your doctors? And also managing daily activities. These patients have a large burden of medical problems, but they need to balance these problems with the rest of their lives, their families, their work, their academic needs. And it can be an awful lot for families and patients to juggle. Young adults need to identify their necessary adult providers, usually in multiple subspecialty areas. They need to also align insurance coverage to make sure that they're getting the medical care that they need. And as young adults move along, they need to be aware of family planning and reproductive options. Fortunately, there's several NF-specific reference articles published in the medical literature. We've highlighted them here. I don't have a lot of time to review the specifics of them, but both of them address readiness for transition in adolescents and young adults and provide some solutions for how to address this in patients with and without developmental disabilities. We recognize numerous barriers to transition. Some of these have already been mentioned this morning. First, as the earlier slide highlighted, there can be a big difference between the pediatric and healthcare models. Youth often have a hard time understanding the adult healthcare model because it is so different, and sometimes they are not provided with a good introduction to how they need to transition their care. We all know that there's a limited number of NF clinics across the country, but when you start looking for adult-specific NF programs, that number is even further limited, and it may be hard for patients to find the expertise that they need. Often once patients get to clinic visits, there may not be enough time because there are so many medical issues to discuss, may not be enough time to sort of talk about the components of transition and how that will be facilitated. Families and youth may also feel anxious about moving to a new doctor. Many patients have been in the same medical center literally for 20 years because they presented very early in childhood and have been monitored for birth, and it can be very hard to trust new doctors, find new doctors, and develop those relationships. Often, again, youth may feel unprepared to manage their health care. It can be very overwhelming to have so many medical problems and take all this on without enough support. There may be limitations in insurance of where a patient can be followed, and this can really dictate care in many situations. And there may be financial limitations if a patient wants to get specialty care outside of their local area, and they have a hard time paying for this. Certainly, there are many significant potential consequences of poor transition. First and most importantly, there can be fragmented care. Medical issues can fall through the cracks when care isn't provided by a knowledgeable provider or within a centralized NF program. If patients don't have appropriate guidance, there can be poor adherence to medical plans and to medications. There's potential for incorrect and delayed diagnoses, as well as potential for incorrect and delayed treatment. Ultimately, this will lead to the quality of life of these individuals being impacted and truly can increase morbidity and mortality in these populations. Fortunately, there's some proposed solutions, and we'll say a little bit more about these, and Dave will elaborate on this, but it's important to recognize these challenges, to provide support and education for young adults transitioning, to provide education and support for NF providers, and to support ongoing NF research in these areas. First, as we're talking today, the CCAB has recognized this challenge and are meeting it by developing this subcommittee to address the issue. When we think of how to support and educate young adults in these matters, there's the opportunity to develop transition of care materials, binders, guidebooks, roadmaps that can help assess what medical needs are and where patients need to go with them to get the appropriate care. There have been important collaborations between the CTF and other NF organizations to develop and promote these transition of care materials. And Dave's going to speak a little bit more about the NF Collective. There's also the opportunity to develop digital apps as well as educational webinars for patients and families to help. And then again, there's another opportunity to certainly leverage CTF website, the CTF website, the NF forum, and social media for outreach. And I'm going to hand it over to Dave now.
Thank you, Tina. This was wonderful. There's a lot of information that you went through, and I was hoping to just share one of the patient brochures that has been put together. So you can see some of the healthcare transition resources that are on this slide, and I'll focus on the NF Collective, and I just wanted to share a little bit of information with you about that. And let me make sure that I can move this one forward. Well, there we go. Okay, so this is a guide that was put together by the NF Collective, and you can see on the lower part of the slide, this is a group of different educational and support foundations for NF throughout the United States. And with an initiative, people have come together from the leaders of each of these groups have come together jointly to work on different proposals that really affect all individuals with NF. And it's been inspiring to be part of this team. The second major project that we worked on was this initiative of transitioning from pediatric to adult health care, which can be trickier than it sounds, as in their overview. So this was a group effort to define what are issues with transitioning, and it was wonderful the way it came together, because the key components of this are breaking things down over the course of starting the transition process at around 11 years of age and just beginning the discussion. And so it's broken down. This is a collection out of a 20-page pamphlet where you can see that there's different areas where you can focus on hopefully at the age appropriate and maturity appropriate level to get you through that decade of transition. And at the end of the pamphlet, there's some additional resources that you can take a look at as well. So one key component that is discussed throughout the pamphlet is this idea of having a readiness assessment. And there are many different forms that can be used. This happens to be one, but whatever your clinic decides to use as an assessment, as people are going through, as families are transitioning and recognizing that they have to pass care on to their child, just continue to use it. As they get more familiar with it, you do this once a year, you have a sense of how things are transitioning. This is another transition readiness assessment questionnaire that's used in many subspecialist offices as they transition individuals through their care. And it's been validated, it's reliable, and it's a one-pager. It's pretty straightforward. You can see some of the questions that come from this. It's medications is of course key. Keeping appointments. It's surprising how many adolescents just assume that things happen, and it's amazing. So all they have to say is, no, I don't know how to do this, and they'd be very honest, and you can devote a little bit more time to it. This one was developed through East Tennessee State University, and I think it's been utilized by a lot of different groups. So again, part of the proposed solutions, support and educate NF providers. What the pamphlet was for the NF Collective was primarily focused for families and young adults as they were starting to take on. But there's also support and education for the providers themselves. And I think most institutions now are recognizing this. It's not just for NF, but certainly any pediatric care transitioning to adults needs to be addressed within any pediatric facility. So here are some existing guidelines that people can keep in mind as they go through the transitioning process and share the recognition that there are surveillance issues that other healthcare providers may not recognize, and then of course management if a manifestation were to present itself. So with that, I just want to close out. This has been a proposal from the CCAB. It's been supported with all of the team members, and it's recognized that transition really does need to be addressed. Thanks for your attention. Questions?
Thank you so much, Drs. Rosser and Viscaccio. We have a number of questions from the audience, and I want to remind all of you that the question box is on the website right next to the video, so please keep them coming. The first question is an anonymous question, and the question is, hi, with the managing daily activities, is there an occupational therapist involved?
I mean, I think there can be. It just depends on the patient and their needs and the age of the patient. For any given patient, their needs are gonna vary, and it vastly depends whether that's NF1, NF2, or schwannomatosis we're talking about. But any critical providers can be integrated into the transition team.
And this question is for Dr. Viscaccio from Dr. Peltonen. Is the guide to patients and caregivers on transitioning to adult care available?
Oh yes, I should have mentioned it's on the NF Collective website, and it was kicked off in February, so it's easy to download. It's well easily read, but it was kicked off with a webinar that was in February, and that's also available. It was an hour-long session with young adults, actually even middle-aged adults, who went through that transition process and had a vivid memory of what they went through, and they shared a lot of their experiences. So both of those are on the NF Collective website.
Great, thank you. Is there a website, Dr. Viscaccio, for the NF Collective that you could share?
Yep, it's just NF Collective, NF space Collective, and that should take you right there.
Terrific. And this question is to either of you. I know it's a topic we've talked about quite a bit on the CCA. And this question is from Dr. Shorey. Do we have data on how many of the NF Clinic Network clinics have a designated adult NF clinic available versus other strategies for transitioning?
I think that information should be available. I don't know that off the top of my head. We'd have to check with Heather, but that is something that's assessed annually, I think.
As Scott pointed out, Heather knows all. And so we don't keep that up in our head. We just say, well, let's connect with Heather and she'll fill us in. Yeah, but I bet it's about 2/3, isn't it? About 2/3 of clinics.
And Heather would remind us that that's part of the application and
yes.
renewal annual report that all of the NFCN clinics actually complete, that talks about what the transition care model is or is planned to be. I have to say, when we reviewed the document, I probably am not doing a good job with my 11 and 12-year-olds of beginning this process in clinic, nor with my own kids. But clearly it's a process that needs to start many years before an individual turns 18, in particular with our patient population, where some of them may need ongoing guidance with regards to medical and financial decision making. It's super important to begin that process many years before. At least in the state of the clinics where I am, or an updated neurocognitive assessment has to be done within 6 months of the child turning 18 in order to establish some guardianship or co-management. but I'm sure that may differ a little bit from state to state, or maybe it doesn't, but surely we need to start much younger than we are. Other questions from the panelists that we have today for our speakers? Great. Thank you so much, Drs. Rosser and Viscaccio. And we are again going to pass the torch to Dr. Laura Klesse. She's going to speak today about patient access to novel NF treatments, current clinical practices, and identification of barriers. And please, if you have questions as the talk ensues, feel free to just type them out as it strikes you.
Thanks, Nikki. So I'm Laura Klesse. I'm a pediatric neuro-oncologist down at UT Southwestern in Dallas, and it's my pleasure to present to you some of the data on a survey we did to the NF Clinic Network, looking at kind of current practices in the ability to give patients potential FDA-approved on-label or off-label therapies, and what barriers there might be within the clinics to do that. So as we all know, NF1, NF2, and schwannomatosis are genetic tumor predisposition disorders that are variable in terms of the symptomatology in patients and the timing of when those symptoms arise. Unfortunately, we also all know that there are very limited therapy options and very few clinical trials overall. But there have been some trials and some medications that have shown some efficacy. And so what we really wanted to know was, what is the current status of being able to offer those to patients with NF? And so we turned to our NF Clinic Network to really look at that. So you've heard a lot about the NF Clinic Network over the past several talks, but at the time of this survey, there were 65 clinics within the US. That clinic network is now open to Canada, as you've heard. And the network is overseen by the Clinical Care Advisory Board. This really entails an application in the beginning and then annual updates, really with the goal of trying to standardize as much care for patients with NF as possible. So we put together a survey to really look at the NF Clinic Network's current practices for the use of medication in patients with NF1, NF2, and schwannomatosis. So we looked at first the on-label FDA-approved medication. So solumetinib was approved by the FDA about a little over a year ago. And so we wanted to survey current practices in the use of solumetinib, and then also to look at other FDA-approved medications that have been used in the past with varying levels of evidence off-label for patients with NF, NF1, NF2, and schwannomatosis. Our goal was to explore the comfort levels and then to look at what barriers people felt that they had in trying to offer those therapies. And our goal was really then to say, are there clear areas where education might be helpful for some of the clinics in either how to prescribe those medications or how to try to get around some of those barriers? So the survey basics. So this was a Survey Monkey link that was sent to all 65 NF Clinic Network clinics in March of this year. We had the survey open for 5 total weeks. It got an initial email and then 2 very nice reminders from Heather. It overall had 25 questions, really looking at some of the basic clinic information, which I'll go through, and then following that, looking at both comfort levels and what people felt like were barriers using a 5-point Likert scale for each of the medications. Overall, we had 51 responding clinics, 51 responses. 10 of those had to be excluded because they were either duplicates. We had asked for the clinics to just have 1 respondent, and so we sometimes had 2 respondents from the same clinic, or there were ones that were incomplete. Someone had started the survey, stopped, and then went back and completed it at a later time. So overall, we had 63% of the clinics in the NF Clinic Network that were included in the final analysis, so 41 of the 65 clinics. And you can see over in the pie chart on the right, the specialty departments that the NF clinics are in that completed the survey. So about 40% of them were in oncology, whether that's defined as neuro-oncology or hem-onc in general, 34% in the genetics department, and then 24% in neurology. So the majority of the surveys that were completed were done by the physician within the clinic. So 36 of the 41, 5 were completed by the clinic coordinator. And overall, the majority of the clinics are pediatrically served pediatric patients. So you can see in the pie chart on the right, the breakdown of the clinics. So in blue are pediatric focused clinics. In red are adult focused clinics, and then green that serve both patients with both pediatric and adult patients with NF. So overall, that meant 90% of the clinics saw pediatric patients, almost 40% saw the adult patients. And then the breakdown of the demographics on the bottom chart are the types of NF patients seen within the clinic. So 100% of the clinics saw patients with NF1, 88% of the clinics saw patients with NF2 as well as NF1, and then 56% of the patients at clinics saw patients with schwannomatosis. And you can see if you look at this chart that the majority of clinics see patients with all 3 types of NF. Some are more focused for patients with NF1 and NF2, and then a smaller focus solely on patients with NF1. Of the clinics, there's a pretty wide variability in the number of patients that they see annually. So the patient volumes annually, and this is individual patients that are reported to the NF clinic network, ranges from anywhere from 981 patients seen annually to 37 patients. So the average was about 278 patients. And then we asked the clinics, do you have any clinical trials open over this past year for patients? And you can see that the majority of clinics did have at least one trial open. Most of those were focused on patients with NF1, with 78% of the clinics reporting an open clinical trial. 27% of the clinics had an open trial for patients with NF2, and then about 20% had no open clinical trials. And then over the past year, we know there have not been trials open for patients with schwannomatosis. So the first question was, what is your comfort level with use of solumetinib for its FDA indication, patients with progressive or symptomatic unresectable plexiform neurofibromas in pediatrics? So overall, the majority of clinics were comfortable with the use of solumetinib for its indication. So this is looking, green is high or complete comfort on the 5-point Likert scale. So between a level of 4 or 5. If you look at that, 93% of clinics overall were comfortable with the use of this medication. 4% had no comfort or very low, and that gave it an overall weighted average of 4.68. So really quite comfortable with this indication. And of the clinics that answered the survey, 90% reported that they were prescribing it for at least one patient. When we asked what clinical department are the patients receiving the solumetinib, the majority of clinics did report that it was prescribed by the oncology division, again, whether that's hematology oncology or neuro-oncology specific, but about 29% or 12 of the 41 clinics were prescribing that within their genetics or neurology divisions. We asked the clinics, though, what did they feel were barriers to being able to prescribe solumetinib? And 37 of the 41 completed this part of the survey. This was a 5-point Likert scale going from least difficult, so 1 on the lower part, to most difficult, which would be a 5. And you can see the breakdown here. Number of clinics is on the left of this axis. And we looked at 4 of the most common reported limitations. By far, the most significant barrier that was reported by clinics who are using this medication is difficulty with insurance coverage. And that's shown here on the left in the red bar. 7 clinics reported this was the most difficult, or a 5 on the Likert scale. Overall, though, this was the weighted average of this was about a 3, so more in the middle. The other barriers that were most commonly noted were barriers in pharmacy, patients' resistance to the medication, whether that's potential concerns for side effects or for surveillance, and then COVID-related difficulties was equal as well. There were 4 clinics who responded to the survey who said that they were not currently prescribing solumetinib for its FDA on-label indication. We had asked if there were a number of potential barriers to its use, 10, and here reported the 5 most common reported in these 4 clinics. Overall, the most common reported barrier was that they did not have patients that they felt were eligible, or eligible patients were currently enrolled on a clinical trial. Other ones that were rated more highly were patient side effect hesitancy or hesitancy to surveillance. Some noted barriers were also COVID-19. We then switched in the survey to ask about medications that are FDA approved, but not approved specifically for use in NF, so what's known as off-label use. We had 38 clinics who completed the remainder of this survey for this. And of those, 33 of the 38, or 87%, reported that they were using a medication off-label for patients with NF. Medications were given as both part of a compassionate use protocol and then off protocol use. Of those, we asked, how many patients do you have on off-label medications? And this broke down pretty consistently, with about 40% having more than 10 patients, 42% having less than 5 patients, and then the remainder of the clinics in between. Just to note, because we did get several questions on this, we did not survey the indications for use for off-label medications. So how you were using them or why you were using them. We really only asked, are the NFCN clinics using off-label medications? So the next question looked at off-label medications for NF1. And so what we did was we asked the respondents to rank their comfort level using that 5-point Likert scale. So if you had a 1 or 2, you had no comfort or very low comfort. 3 was in the middle, 4 or 5 was very high or complete comfort using the medication. And you can see in the graph over here on the right, the green bars are the high or complete comfort using the medication, and the blue bars are no or low comfort. By far, the highest comfort level was the use of MEK inhibitors. This was followed by the use of everolimus for patients with NF1, less comfort with imatinib or cabozantinib. We then looked at the use of off-label medications for NF2 or schwannomatosis. Again, 38 clinics answered these, and just as in the last one, the green bars represent high comfort or complete comfort using these off-label medications. The red bars here are moderate, and blue is no or low comfort. By far, the most comfort was with the use of bevacizumab, with 66% of the clinics responding being completely comfortable. This was followed by a high level of comfort for everolimus, everolimus and MEK inhibitors, as well as aspirin. The lowest comfort levels were with the use of ALK inhibitors or lapatinib, which is over here on the far right. And you can see the weighted scores at the top of each of these graphs. So the weighted score for the use of bevacizumab was over 4, whereas the comfort level weighted for the use of ALK inhibitors and lapatinib was little under 3. We asked for patients with schwannomatosis whether or not clinics were comfortable with the use of bevacizumab, and this broke down by about thirds. So about 31% were completely comfortable, about 30% were in the middle, and then about 31% were not at all comfortable with the use of this medication. The final group of medications we queried was whether it was the use of pain medications. And we really asked for two specific groups of pain medications, tricyclic antidepressants, and then serotonin and norepinephrine uptake inhibitors. And the results are over here on the right. So again, green represents a very high or complete comfort with the use of these medications. Blue here is moderate, and red is low or not comfortable. And with the highest level of comfort in the clinics was tricyclic antidepressants, with 61% of the clinics being completely comfortable. And then with serotonin or norepinephrine reuptake inhibitors, about half or 47% of the clinics were comfortable. So knowing this kind of breakdown of comfort level with the medications, our next questions were, well, what do you feel like are the barriers, particularly for the clinics that are not using off-label medications? So first of all, for clinics who were using off-label medications, insurance coverage was the reported most difficult barrier, with over 48% of the clinics ranking it the highest. And it had an overall weighted average, remember on this 1 to 5 Likert scale of 3.85. Interestingly, COVID-19 was felt to be the least difficult barrier of all the ones we surveyed within this group. 5 clinics reported not using off-label medications for patients with NF1, and this is the results of those 5 clinics are shown in this diagram to the right. So again, remember, low is 1 or 2 impact, 4 or 5 has significant impact. And so in red are the results where clinics felt like this was a significant impact to their ability to use off-label medications. And the highest one was familiarity with the option. So of the 5 clinics, this ranked the highest with a weighted score of 3.6. After that, the most common reported limitation for use of off-label medications was insurance barriers, followed by patient concerns and side effects. So overall, the conclusions of this survey, there seemed to be a really pretty high level of comfort for the use of both on-label and off-label medications in the NF Clinic Network clinics, but there are a proportion of clinics, and a pretty significant one, that really are reluctant or face significant barriers to being able to prescribe these medications. As I showed you, the on-label use of solumetinib was reported higher than the off-label, but there still were a significant number of clinics in both of these groups that either had barriers or were not prescribing. Insurance coverage was the most consistent barrier noted by clinic personnel as the barrier to using these therapies. And I think it's pretty clear that there are some potential uses for ongoing education for clinics that either can't or have not been able to prescribe them because of the obstacles and barriers, or not completely comfortable. From here, I think there are a couple of other steps to move forward. So this is the preliminary analysis of this data. We are going to analyze this data further to see if we can identify some correlations between accessibility and barriers, really looking at some of the clinic demographics. Are adult clinics more comfortable with certain medications than the pediatric clinics, and vice versa? And is that a way we potentially can focus some education? And then there's an upcoming survey looking at patients, really asking about their experiences and potential concerns or barriers to the use of some of these medications. And all of this is our goal to try to help develop more educational programs or other interventions so that we can try to give patients as much access to novel therapies as feasible, as we hope that more and more novel therapies come. And so I'd just like to thank the NF Clinical Care Advisory Board. The names that are italicized here are the ones that were part of this barrier group, and I'm happy to take any questions.
Thank you so much, Dr. Klesse. I have 2 quick follow-ups that came from the talk before. Dr. Viscaccio has provided us the NF Collective website. So it's www.nfcollective.org. And there's also a click down there for resources. And one of the previous questions was, do we have data on how many of the NF Clinic Network clinics have a designated adult NF clinic available? And I know you presented some data, Dr. Klesse, that at least on this survey, 90% of clinics saw pediatric patients and 40% saw adult patients. And I know even within that, it's not perfect, but some clinics are exclusively pediatrics and some are exclusively adults. So definitely less than half of the pediatric clinics have an adult clinic to transition to. So that's something to definitely keep in mind.
That's exactly right. And it's a very small percentage that are adult only.
Correct.
We clearly cover more pediatric.
So we have a number of questions from the audience. Two have to do with just the demographics of the clinics itself. So how is the number of patients seen annually by a clinic defined? Is this one patient over the course of a year or multiple times during the year? Thank you.
It's a great question. So the answer is we want unique patients. So one patient over the course of the year. So even if you have that patient on therapy and you see them every month, every 3 months, that's considered one patient for the NF Clinic Network. So we want unique patients seen over the course of the year.
Great. And we have another question about when I think this means when clinics responded to the question, were they involved in clinical trials? Were those clinical trials therapeutic, or did this also include descriptive or natural history studies?
So this particular question asked about therapeutic trials, not descriptive or natural history. This was more geared to kind of the ability to give, to offer patients potential novel therapy. When clinics fill out their annual survey that for the clinic network and for kind of revalidation as part of the clinic network, all clinical studies are included. So that would include descriptive, natural history, all of those. But this in particular was really focused at treatment.
Excellent. And then the last question from the audience is, when you query for comfortable, were you asking whether or not the sites felt a particular agent should be prescribed for the indication, or whether they understood how to prescribe and manage side effects?
Yeah, so that's a very good question, and one we got asked several times in the midst of our survey. So no, we were not asking whether or not you agreed with the use of the medication for a particular indication. We really were just asking, was your clinic or your institution comfortable with using that medication, looking for side effects, knowing how to manage side effects? So really not specifically asking about the indication itself. I think that's probably a very good next thing to talk about, but we really have not, we really didn't ask that. We really just wanted to know, is this something you potentially could offer your patients?
Great. And I just want to reiterate what an amazing thing it is to see the data coming out this morning and as it's been presented, so we can take a closer look at understanding delivery of NF care, what some of the obstacles are to delivery of NF care, what are some of the obstacles in terms of access to novel therapies. And we also really thank the NF Clinic Network clinics for responding to those surveys, because that's how we learn where the gaps are. And as we continue to analyze the data thus far, we will really get some targetable areas for moving forward, and where can we spend some time doing some education and intervention, both on the clinician side and on the patient side, in terms of barriers and bringing the whole community forward in terms of our knowledge and access. And then I want to offer everyone the opportunity to take a 10-minute bio break and stretch. And we will return for what's always my favorite part of the clinic symposium, and that is this time a virtual case conference. And this will be an adolescent with NF1 related complex medical and psychiatric issues. So Feel free to get up, walk around, do some jumping jacks, and take a bio break, and we'll see you back in 10 minutes. Thank you. Welcome back, everyone, and I hope you're refreshed and ready for this exciting case conference. I'll be moderating this session. Dr. Pamela Trepane from University of Florida, Jacksonville will be presenting the case. And we have an esteemed expert panel, which includes Dr. Rosalie Ferner from Guy's Hospital in the UK, Dr. Laura Clessy, who you've already met from UT Southwestern, and Dr. David Viscaccio from University of Utah. Thank you so much for returning with us, and we look forward to hearing about this exciting case.
Alrighty, so I am Pam Trepane, and I will be presenting this case of an adolescent with complex medical and psychiatric issues. We do not have any financial disclosures today. Our objectives are to be able to identify the warning signs of a malignant transformation of a plexiform neurofibroma, order the most appropriate imaging modality for a suspected malignant peripheral nerve sheath tumor, and to evaluate the findings of the imaging to determine the most appropriate treatment modality. Our patient is a 12-year-old female who was referred to our neurofibromatosis clinic to establish care. She was new to our area and had no NF care for the past 3 years. They had been traveling and had moved frequently and wanted to wait till they had established themselves back where they knew they were going to create their home. She was clinically diagnosed at age 4 with NF1 based on the presence of multiple cafe au lait macules and a plexiform neurofibroma of the right upper back in the scapular region. She subsequently went on to develop intertriginous freckling, Lisch nodules, and a dystrophic scoliosis. Her primary concerns when she was establishing care in our NF clinic: over the past year, she had had progressive enlargement and texture change of the plexiform neurofibroma on her back. And then hydrocephalus due to aqueductal stenosis. Prior to her appointment in our clinic, whenever she had arrived in our area, she had first went to orthopedics, and they had obtained spine radiographs and a CT scan of the spine, and also had been evaluated in neurology, where she had received a brain and spine MRIs. So we had this information for us when we evaluated her in our clinic. On physical exam, she had a non-tender, well-encapsulated, firm plexiform neurofibroma on the right scapular area. And you can see that in the photograph and the approximate size with the tape measure over it. She had severe scoliosis with right curvature and kyphosis, and her pelvis was not aligned when standing. Neurologically, she had mild ataxia with heel-to-toe gait. Strength, she had somewhat diminished strength on the left upper and lower extremities, decreased strength of the left sternocleidomastoid and trapezius muscles. On the right, she had 5 out of 5 strength on the upper and lower extremities. Cranial nerves were grossly intact, and her DTRs were symmetric and 2+ throughout. So we went back and reviewed her prior imaging. She had extensive plexiform neurofibromas, with the predominant one being the one over the right scapular area in the posterior mediastinal and paraspinal soft tissues, extension into the right neural foramina extending from T4 to T9 vertebral bodies. There was no intradural extension, and there was no spinal cord compression. And you can see the plexiform here, and you can catch a little bit of the edge of it right here. She also had a brain MRI for review. She had asymmetric enlargement of the left midbrain, pons, and inferior cerebellar peduncle, and compression of the aqueduct and part of the fourth ventricle. There was associated dilatation of the lateral and third ventricle, and there was transependymal periventricular CSF flow. And you can see the asymmetry here, and then 2 of the crosscuts of this aqueductal stenosis and the resulting ventriculomegaly. She had a very significant dystrophic scoliosis, and you can see that here on the X-ray and then with the 3D CT scan as well. It was almost at a 90-degree curvature. So there was levothoracic curvature centered at T4 to T5, and dextroconvex, dextrorotary, and thoracic curvature centered at T7 to T9. There was a relatively milder levoconvex lumbar curvature, and the thoracic vertebrae were dystrophic and dysmorphic, as were the ribs where the curvatures were. Additional pertinent history. By report, she had had precocious puberty. However, secondary sex characteristics did start at about age 9, with menarche at age 10. Bone age previously had suggested advanced bone age. She was also followed in psychiatry for a variety of behavioral concerns, including ADHD, oppositional defiant disorder, bipolar disorder, and she had previously reported thoughts of self-harm. She was displayed aggression primarily towards her mother, and she was currently followed by psychiatry and was on a number of psychiatric meds, including Abilify, Clonidine, and Intuitive. So now we're going to pivot to our expert panel with this myriad of different findings that our patient has. What would be some recommendations of the next steps, and what would you do next?
So maybe we can go one by one. This is clearly a challenging case of what first, I think. Dr. Ferner, would you like to take the mic first and talk to us about what you're concerned about most? Because I think there are a lot of different things to be concerned about with this case.
Yes, so this is a very complex problem that this patient faces. So whilst we're being told about a plexiform neurofibroma, I have to juggle in the back of my mind that she has 3 other competing issues. The brain, which is potentially life-threatening if that's acute, the bone, and a pretty significant psychiatric history, and that may influence my decision-making. But if I confine myself to the plexiform neurofibroma, we're told it's not painful. That doesn't put me off. It's growing. I couldn't quite see on the tape measure how big it is, but it looks significant. And I'm pretty concerned about a change in texture, because from our experience, about 1/3 of them are malignant. So I also think about her age, and I'm aware that malignant change is less common in younger people, but that again hasn't put me off. So I would want more information, assuming that there is no compelling reason to look at the brain, that it's not an acute issue. I'd like more information about the plexiform, and I'd use a different imaging modality. Do you want me to stop or go on?
Would you like me to give you a little bit more information about the plexiform?
I'd like to know the size, please, and how quickly it's grown.
So the quickness of the growth has been a little bit harder to judge based on the family's knowledge and really trying to determine what's going on with an adolescent. But it has at least been growing over the last several years. It's about 6 to 7 centimeters to 9 centimeters on the surface when you're rolling the tape measure over it. When you're in clinic and you run your hand over it, it is hard to touch. It is not soft. It is not squishy. It's pretty solid, hard mass.
So that would really prompt me to undertake a PET scan. And there may be some debate about which form that you would take. I would use fluorodeoxyglucose, and I would use what I use in my unit. And I know that different units have different protocols for PET scans. So I would use the for us, an FDG PET CT, simply because our unit is most aware with the last 20 years experience of using it. Other units might use MRI because of less radiation. That's up for debate.
Dr. Ferner, while you have the microphone, I'm curious, if I were seeing this patient in clinic, I would be concerned right away. And even just looking at the pictures, it makes me concerned. So I think it might be helpful to talk about what kinds of things would make you concerned in seeing a patient with a plexiform in clinic.
Yes.
And it's just the picture, and I guess it's just the picture alone a concern.
Yes, the picture is a concern. It's growing. I mean, one has to evaluate, because in younger children, as we know from Brigitte Wiedemann's studies, particularly in Eva Dombey and co, plexiforms grow more rapidly in children. But this seems to be a large plexiform, and from what you're saying, it's hard, and that would be a big red flag to me. Not all malignant peripheral nerve sheath tumours are painful, and indeed some benign tumours are painful. But the size of the tumour, the growth, and the hardness of texture would make me immediately concerned. But I think in evaluating MPNST, there are extremely important factors to take into account, because it's no good zooming down the level. And I totally agree with you, Nikki, that I would be doing some urgent investigations. But I would actually have to say, I would triage that patient and say, if that was an acute hydrocephalus, that would trump it, because it's potentially life-threatening. And so you need to evaluate the patient not in isolation, but those with the red flags, the growth and the change in texture. I mean, out of 108 patients, we have only 6 are under the age of 14. So it's much less common, but that doesn't put me off. What I see would be concerning for malignancy.
And Dr. Viscato, anything to add to that in terms of what your next steps would be?
No, I think the PET scan's the right way to go, just focusing on the plexiform. It doesn't sound like she's having CNS symptoms with the hydrocephalus in the U.S. But those ventricles certainly are worrisome, and it can be pretty sudden. These kids can really over a month it may really advance. So I can't believe that this is not painful though, and I just wonder if as you're palpating around the edges and you mash in. So a lot of times they'll say it's not painful until you start pushing. And then you start pushing and you see the flinch and you go, oh, okay. Some kids are just tougher that way, I think. But I'm intrigued that Dr. Ferner, you've seen plenty that did not have pain as a transformation event took place. So it's I got to keep that in mind, because usually pain is so key for us.
I agree with you, but she's still got an enlarging hard tumor, and we've surprisingly seen painless high-grade MPNSTs.
Yeah. So the other thing is that, we do see the absence of the bullseye lesions on that. So that's always concerning, that it right off the bat, you can look at it and say, is this an atypical a NUB-P, or is it a low-grade MPNST? It's worrisome just from the MRI look as well.
And Dr. Klesse, assuming you agree with moving forward with the PET scan, can you talk about what you would order? Would you just order a PET scan of that body part? Would you get a PET scan of the whole body? Would you get the CT with it, especially if the family is concerned about radiation exposure due to the CT? And are there any other sequences on MR imaging that might be helpful to delineate whether or not this is a standard plexiform neurofibroma or whether or not it's begun to exhibit malignant transformation?
It's a good question. Yes, our radiologists sometimes will talk about some contrast changes as being helpful for malignant degeneration, but I totally agree with the panel. I would move forward with a PET scan. I just think that's your highest yield. You have a good MRI that I think we all agree looks very suspicious at this point, and so I probably would move forward with that. We tend to do basically skull to thigh, just as part of a metastatic workup as well. This is the one time I do talk to families that I feel like the radiation risk is worth it. And so I definitely would.
Yep. I just wanted to comment that there are some sequences on MRI, so diffusion weighted imaging may also show some areas of restricted diffusion within, and so that's if it's something I would probably order it ahead of time on this patient, and so it's very likely that you would see some restricted diffusion within that large mass itself. But I suspect Dr. Trepane is going to show us the next imaging study that was completed.
So we did exactly that. We had to triage what we thought was the most critical, because we also had some competing teams. People were worried about her hydrocephalus, wanting to know what the pressures were, people wanting to repair her scoliosis. And we were the most concerned about malignant transformation. So we did go ahead and order a PET scan. And it was indeed intensely hypermetabolic. And you can see here it lighting up in the two different views on the whole body scan. There were no other abnormal metabolic sites. There was an SUV max of 0.06 in the right posterior pleural soft tissue, but that was way below the obvious up in the where the plexiform is. And the hydrocephalus seen prior was similar to her prior MRI. So it was not changing on at least the CT that accompanied the FDG PET. And again, the SUV max was 29.3. Subsequently, we checked back with our radiology team, and where we had sent her, this is lessons learned about assuming that you know what you're saying and what the receiving end is doing. They have one PET scan protocol, so it was just a 1 4-hour, it wasn't a delayed read. So everybody just gets the one report of an SUV max.
So concerning or not concerning? I think we'd all agree that that's a pretty concerning SUV. And I'm not sure we would agree necessarily on what the next steps would be. So maybe we'll start this time with Dr. Klesse.
So I think that needs to come out. The question of biopsy versus complete resection, I would have to talk to my surgeons. I always tend to push for resection if that's feasible. And so that would definitely be my upfront. They really felt like it wasn't completely resectable. That's when we tend to biopsy. But I would sure like that really hot lesion out.
And Dr. Viscaccio, do you have any thoughts about biopsy first versus going directly for a complete resection, especially in this situation where it looks to me, being the non-surgeon, that this might be able to be resected completely based on the location, and maybe talk about the advantages and disadvantages, if you will.
Well, I think what I've heard from our surgeons is that you just don't want to muck up the field. And if you go in for a biopsy, you just don't know what's going to be trailed. And from that MRI, I think you got a pretty good look at how the planes could actually pop this right out. And it'll be a wider resection, of course. They're going to want to make sure that they have clean margins. And so for this particular one, I would say that they would probably go to full resection, wide resection. And you'll get to the chemo adjuvant therapy, I suppose, down the way. But just in general, we have opposing opinions from our sarcoma specialist, where some will not go in without a biopsy, and others just say, I know what's there, and I'm not going to biopsy because I just want to get that out. That hot potato, is that what you called it, Laura? Hot potato. You got to get that out, and you just don't want to leave any residual behind.
And we've used a lot of biopsies in places where either the diagnosis is not as clear or it's really questionably resectable up front. But I agree with you guys as a total non-surgeon. Doesn't this look like it should be resectable? And so I'd sure push for that too.
And Dr. Ferner, your thoughts on complete resection versus biopsy?
I just wanted to, if you don't mind, make a comment about the PET, because I just want to emphasize that every unit has its own protocol, and some units are doing qualitative PET, and some are doing semi-quantitative with the standard uptake value, the SUV. And SUV cutoffs vary between units and the timing varies, but one would agree that this SUV is very high. Just as a small caveat, this clearly looks like a plexiform and its location is very consistent, but we've been caught out with internal tumors that had these high SUVs and have turned out to be lymphoma. So I agree with Laura that sometimes there is a case for biopsy. I am not at all a surgeon, can't sew a button on, and I would always take advice from our sarcoma team. But I agree with both of you that this looks like it could be removed in its entirety with wide margins. I also factor in that this young child has significant mental health problems, and I want to get to the fastest a solution for her in this case. I guess if I saw heterogeneity on the PET, it might influence me a little bit more to look at different regions. But I think in her case, I would go for complete resection.
And we have a few questions from the audience as well. One of them was about repeating the growth rate of the plexiform. And I think Dr. Trepayne, you commented that that's a bit hard to establish just given the intermittent follow-up of the patient. So it may not be able to really clarify for us the exact growth rate. Is that correct?
That's correct. The prior to her seeing us, it had been about 3 years from time when she was seen in an NF clinic, and then had just been kind of free floating and nobody was really paying much attention to it. It wasn't giving her much trouble. But in that 3-year period, we don't know if it's been slowly growing over the 3 years or if there's been an immediate rapid growth, say in the last 6 months.
And either of those would, I suppose, be concerning in this scenario as well. The two next are comment and question, and they're fairly similar to one another, so I'll read them both one after the other. And there's a contrary opinion as well. So the first one is that the plexiform looks fairly superficial and therefore should be less risky for debulking. Is a PET scan necessary? Maybe just removing as much as possible would be worthwhile so you can be more confident of pathology and not have to worry about MP and ST later. And along those lines, another comment that resection required undoubtedly, looks completely resectable, but a sarcoma resection or an atypical neurofibroma resection, biopsy would be useful to determine the type of resection. And then just to bring the counter comment to that, like a comment that core needle biopsy would not compromise subsequent sarcoma resection or outcome. So it's interesting to see that many different people might approach this slightly differently, but I think ultimately many agree that this lesion needs to come out. And then there's one last question related to the PET. And And then I'll get on to the treatment-related questions. So if the PET had shown an indeterminate SUV max value, for example, 2.5 to 3.5, would you still pursue a biopsy given the size and concerning MRI features, or would you consider observing? If the latter, would you repeat an MRI or a PET? And I will add in when.
So that's an interesting question, because I was going to follow one of the earlier ones to say, even if it was a little more indeterminate, that it looks so concerning on the imaging. Even if the biopsy said it was atypical, I sure would still, if that's resectable, want that out. But Dave, Roz, what do you guys think?
Well, I think it's a great question. And I think all these comments and questions really point to the fact that we're just single agents here representing a very large team. And in fact, decision-making would never be done by one person for all the reason for these comments. So I think that's the thing to underline. That SUV was our original cutoff, 2.5 to 3.5. It was our original overlap region. We've now got very different overlap regions. So for us, that'd be benign. But taking into account indeterminate ones, I think these are difficult. And what one does is PET is just one more bit of information. Above all, we're clinicians. And I think it's been very eloquently put that this has grown and it's rock hard. And those are things that actually bother me. And if it was indeterminate, I would ask the team whether they felt that a biopsy was appropriate, and I think they probably might under those circumstances. And I take the point about the needle biopsy. If I decided that the clinical, say it was a growth and it didn't have the hard texture, and it was an iffy PET, if I was going to re-image, and it's something that I chatted with lots of the sarcoma teams around the world in a very difficult case, we would re-image with MRI in 3 years with volumetrics looking at growth. But in this case, I agree that I would actually continue because of the features that she has clinically.
So I think the one concern I have is the MEK inhibitor now sort of gives us a different approach. If we really thought this were indeterminate, could be mild or not mild, but could be just an atypical, you still wonder how effective the MEK inhibitor will be to even an atypical plexiform. But I think that it just makes you worry more, doesn't it? I think, Dr. Ferner, you wouldn't be sleeping well if you left that in. So let's say that it wasn't hard, it's soft, and you really got to know if it's growing and do that volumetrically. I'm not sure I'd wait 3 years, maybe 3 months. 3 months.
I said, not 3 years. I think I'd
good.
Okay, good. I thought you said 3 years too.
So that would really drive you. But I think now with the MEK inhibitor, you really do start wondering if you can decrease the size of these tumors and give it a chance. But boy, not this one, not when it's that hard.
Yeah, I'd have to be convinced that tumor was benign histologically in all areas before I did that.
Yep. And I think in this particular circumstance with the mental health illness and other factors, whether or not you're going to get this individual back in 3 months is potentially up for question.
Absolutely.
Yeah. And then there are a couple of questions related to whether or not, since all of us seem to be worried about MPNST, whether or not we would consider preoperative radiation and therefore proceed to biopsy and radiation first, followed by resection, and what would be the potential advantages of that approach?
Well, in this case, I don't think there would be any because coming with a health warning that none of us are surgeons, and we'd ask with the team, if it's fairly superficial, it's not impinging on the spinal cord, it looks like it's resectable. We're told, I think, by Pam that it was encapsulated. I don't see the need for preoperative radiotherapy. Also, she's got mental health issues. So how will she manage with that?
And I guess my particular preference in a situation where something is completely resectable is take advantage of the fact that it's completely resectable while it is, and get it out. And then a very important question was brought up with regards to the other medical issues. Now that we have the PET, what do we do about the spine, the scoliosis, and the Chiari in relationship to and potentially obstructive hydrocephalus? I think the CT compared to MR doesn't necessarily make me as a neurologist feel all warm, safe, and happy. So how would the best approach be in terms of evaluating those other important medical conditions, and do they need to be evaluated before surgical resection?
I would say from my standpoint, the spine clearly needs to be corrected, but I think of it almost as the lowest priority at the moment. I definitely think that this lesion needs to come out before that. I probably would repeat a pretty short interval MRI, a 6 to 8 week, to make sure that nothing's changing. But in somebody who's truly asymptomatic, I'm still most worried about this lesion.
Could I ask what you think the cause of the ataxia was?
That was another one of our concerns about the hydrocephalus, is that there was some asymmetric compression or impingement, and kind of knowing what all was going on with her. Was it all just based on the degree of scoliosis? And then is it really ataxia, or is it just because now my gait is off because my spine is going out at a 90-degree angle? It was hard to tell and hard to get a good assessment, but definitely concerning that there was difference in strength between the two sides and not really good tandem heel to toe walk.
Did ophthalmology weigh in on pressures just by their retinal exam, their dilated exam?
Off the cuff, I don't think we had any evidence that she had increased pressure in the back of her eye.
Okay.
I had a question for you, Dr. Viscaccio. If the plexiform had been benign, would you need to remove it before you did anything with her spine?
Oh, gosh. Remember, I'm a geneticist. So I'd follow our orthopedic surgeons. That they talk about these, I don't know, tipping angles where they feel like they're obligated to go in, because she still has a little bit of growth. I know she's got an advanced bone age, and you'd really like to get her through that growth phase before you repaired it in any way. But I think they avoid tumors when they fix the spine. They stay away from, and there's probably a dural ectasia, and we didn't get a great look at the spine, but I suspect there's a dural ectasia as well. So it's going to be a tricky surgical procedure. But yeah, even assuming that this is benign, let's say that a benign plexiform on your scapula, would that deter the orthopedist from going in? I doubt it. I think they would just go around it, and that wouldn't be a problem for them.
Yeah, that's our experience as well, is that our surgeons tend to leave them alone and just work around them. And especially one more off to the side like this, they would, if it truly looked like a typical plexiform, we would leave alone and just fix the spine.
Excellent. So I think Dr. Trepayne's going to tell us what happened next.
All righty. So we took her for a complete resection. We did, we had the same discussion in our site about doing biopsy versus just going for the complete resection. I might have been highly excitable and strong-armed a few people to go straight for complete resection. But it was well encapsulated, likely arising from a paraspinal ganglia, easily dissected from the surrounding tissue without extension into the muscle or chest wall. There was not extensive blood supply, and they placed multiple clips in the base to mark the tumor bed. So as the surgeons like to say, they went in and just shelled it out. They just lifted it out. It wasn't touching anything else. Took it out, clipped the ends, and sent it off to pathology. Here is the pathology read. They read it out as a malignant peripheral nerve sheath tumor. 10 mitoses per 10 high-powered fields, gave it a grade 2 histologic grading. They did not do any lymph nodes or other dissection in the area. The margins, there was tumor present at the margins. This created a deal of discussion between pathology, surgery, oncology, in that the surgeon felt like he took out the entire tumor and that it was well encapsulated. So having tumor up to the edge, it wasn't like he was cutting it out of a bigger plexiform itself. And then all of the histochemical stains and are there for all of our oncologists.
Maybe we could just leave it on that slide for a moment, go back.
Yep.
And comment a little bit on, there are a number of concerns perhaps on immunohistochemistry and the fact that there's tumor present at the margins and a proliferative rate of 60% among other things. And those on the panel had suggested a wide resection to start. So what would you do with this information in terms of thinking about next steps?
So presumably the wide resection wasn't possible. I think it's interesting that it was encapsulated, but it's right up to the margin, because sometimes when you shell them out, you're lucky. I would be discussing other therapy, such as radiotherapy, even though this is a 12-year-old. She's got a high proliferative index and tumor to the margins.
Yeah, I agree with Dr. Ferner. As an oncologist, it's a big tumor, high proliferative rate. I sure would be in positive margins. I worry so much about recurrence that I probably would be discussing other therapy too.
And while you're there, Dr. Klesse, is there further staging that you think would be important at this time?
I think it depends on if you've got good CTs with your PET CT. Obviously, we always look for pulmonary metastatic disease. So if you didn't have high enough resolution CTs, we probably would look for other metastatic disease, no question. But this is, from my standpoint, worrisome enough that we would talk about adjuvant therapy. And I totally agree, we'd probably use radiation here.
And many institutions, probably like mine, have attenuated CT as part of the PET scan, which is not a diagnostic CT. And in that regard, Dr. Ferner, what would you recommend in terms of CT scan and where?
So normally as part of our sarcoma protocol, we would do a CT accepting. Many units will now advocate, I don't want to undermine the people using PET MRI, but whatever you're using, PET CT or PET MRI, we would not accept the PET CT as sufficient and would do a separate chest CT. There's no evidence on the PET of any other reasons, but we would do a separate chest CT. That in the beginning.
Excellent. And maybe you can lead us forward, Dr. Trepane?
Can I just point out, I'm not sure that we use grade 2 so much anymore for MPNSTs, right? It's either high or low grade. and trying to parse that out, it's probably not worth doing. This is a high grade MP&ST.
Yeah.
Others agree?
Totally agree.
Great.
All right, so then follow-up and surveillance. So clearly we needed a multidisciplinary approach with neurosurgery, oncology, orthopedics, ophthalmology, genetics, and psychiatry. So after surgery, the surgical site had healed well without complication. There was, during her surgery, they did put in a probe and measured her intracranial pressures, and it was normal. Her ICP, that's a little bit further down. So they were managed to do that concurrently with the tumor resection. So the same discussion then occurred with oncology about the pros and cons of radiation therapy and repeat imaging, and when should it occur? Should it occur? Should we radiate? And we do have proton therapy available in Jacksonville. So everybody was weighing in. And at the moment, they decided to just repeat her post-op MRI at 3 months and her FDG PET. And at this time, her SUV max was 0. So now you can see where the mass was and where the mass is not at the moment. There was not evidence of any other metastatic disease. The same mediastinal SUV max that was below the threshold was equivocal at that point as well.
And the scoliosis?
Scoliosis, we're getting there. We're going further down. So the aqueductal stenosis, they put the ICP in pressure monitor. It measured 10 to 14 during her surgery. They felt that was normal. And so they have not done anything with her hydrocephalus at the moment. The family did opt to go ahead and start addressing the spine during all of this as well. And so I'm trying to think of her time course, probably about 6 months after we have the tumor out, they went in and did osteotomies and put a cranial halo on to give her some distraction, and got a little bit better, not much, but a little bit better alignment, and then went ahead and did posterior spinal fusion with bone grafting.
But before you move forward, just a few more questions from the audience. Still some, I think, appropriate concern about transpenal edema being present, and that raising the concern for hydrocephalus. I think the questioner had also wondered about idiopathic intracranial hypertension, but in this case, I'm not sure we could say it was idiopathic in the circumstance of the aqueductal stenosis. And I think that's probably, as the neurologist, that would be an ongoing concern of mine in terms of just continuing to monitor that. And then the second question was, would it perhaps have been optimal to have a pre-op diagnosis, do a sarcoma type resection first, and avoid subsequent radiation? And then the last comment with regards to the pathology is that you did note that H3K27 staining in the high-grade part, meaning loss of H3K27 staining, is associated with worse outcome. And I think I was hinting along those lines with a proliferative index of 60%, that despite the follow-up PET not being of particular concern, I think this panel clearly has concerns about this lesion itself. And so it would be helpful probably to talk about how to follow someone like this forward. I think there are a number of sites who may have decided to go forward with a more aggressive resection and or following that up with radiation based on the factors given.
Could I ask why, what the rationale was for not treating the hydrocephalus in a non-urgent fashion, because we've all seen people with this sort of MRI picture who can present acutely being absolutely fine and then acute deterioration. And I just wondered whether a third ventriculostomy was considered as a non-urgent procedure.
That was not considered. I think the neurosurgeons were pretty happy with the pressures being normal when they were in the OR, and have taken an observatory approach, and will circle back at some point to see, what all is going on. And then the other question is too, is if you're in a halo and you're being straightened out, well, some of the pressure, is it innate? Because you do have some asymmetry in the brain itself. That may be causing some local compression, but if we're straightening out the spine, will it make it better, the same, or worse? And so there's a lot of observation that's going on and trying to parse this out in a logical way for a family with a complicated daughter.
And I think the halo might further compound the assessment of the hydrocephalus, however. So as a fellow neurologist, I have to also agree with Dr. Ferner that would be an ongoing concern for me, because if it did make her hydrocephalus worse by correcting the curve, then here she is in a halo, very difficult to really assess the ventricles or get a good sense because of the artifact from the metal. And that would make it very difficult to monitor.
I think this goes back to the NF clinic team that you assemble. And if you've got the same neurosurgeon who has seen those cases that have progressed over a month's time, they're going to have a different approach, perhaps, than a neurosurgeon who hasn't been familiarized with NF1 complications. So it is worth keeping that in mind. And I think sometimes you do have to pound the table, Nikki, and really say that, we've had some experiences, and please go in and do the ventriculostomy, because it potentially would be very effective. And I agree with you. It's going to be hard to follow.
And then I have one last question from the audience regarding the pathology. And Dr. Chapin, you may know the answer to this question with regards to the margins. The question was, were the margins positive for MPNST, or were they positive for plexiform neurofibroma?
So I'm not the pathologist. The way it was read was that at certain margins, the atypical cells went out to the margin.
Got it.
And so, but that's also a really good question on terminology and how people say things. The general consensus was, though, is that this was abnormal to the margin. And then the surgeon was very adamant that the margin, however, was well encapsulated. It wasn't taken out of another bed. So with that, there was a bit of discussion, shall we say.
I think that's a really relevant point, too. Is this a bad peach pit in the middle of a peach, or is it really the whole thing is bad? Because those might be handled somewhat differently if this is a focal area within a plexiform rather than an entire lesion that looks malignant.
Oh, no question, right? I think that's a great point, that if it was benign tissue at the margin, I'd be much less worried and probably would just observe, not move straight to radiation.
Agree.
Can I ask you another question? And that is, how much weight did you put on this pretty significant psychiatric profile that she has in making your decisions?
So, that was a large discussion with the family about what she would and wouldn't tolerate, because she is fairly aggressive towards her mother. They did not feel like she would tolerate a lot of different things. So then, the question was whether to proceed with correcting the scoliosis. Is it truly stable? because now she's becoming, skeletally mature. How long can you stand around with going off at a 90-degree angle? Will she tolerate a halo? So those were ongoing discussions with the family, because, that's the first time we've met her, to know how is she actually going to respond to all of this manipulation to her body. And the parents, I guess I should put on my multidisciplinary approach. It also includes the parents and the patient.
And the psychiatrist, probably.
Yeah.
Yeah.
But she seems to be doing well enough after her spinal surgery and the halo. That, I think, was one of our bigger concerns, is that she's not, the orthopedic surgeons had already talked to them before we had seen them about how this would play out. And not only just rods are painful, but she's going to need a halo, and is she going to be able to tolerate that? So the parents had already been kind of thinking about that before they came to see us. And then we took a left turn at Albuquerque and started talking about this mass on her back that felt really bad. And we kind of tabled some things until we could get that under control. And the hydrocephalus neurosurgery, everybody was playing their part and vying for what was the most important body part. So it was, the epitome of that multidisciplinary approach, and trying to figure out who goes first, and then how do you wrap other things into that, because neurosurgery just wanted to take her in and measure her pressures. Well, can we do that along with removing the tumor, trying to do stacking those surgeries in a way that is kind to her body and time-wise and ability to cope.
Excellent.
All right. So the only other part that we had left to do, besides trying to get everybody in the same room, even if it is still virtually on the Zooms, was doing molecular testing. Our hypothesis going in was that she would have a whole gene deletion. She did not. She had a de novo point mutation that led to a premature stop codon. So the parents had been sort of concerned before all of this if the other kids also had NF1. After all of this has sort of played out, we saw some of the other kids in clinic and they did not meet the clinical criteria. And now we actually know her pathogenic variant as well. All right, so those are our objectives again. And I don't know, Nikki, if there are any other questions or if our panel has any other comments or concerns. We have right up until the hour, I think.
Yeah, we've had some excellent questions come in. I didn't know if there were any, while we're waiting to see if any further questions roll on, if the panelists have any further comments.
I just wanted to follow up Dr. Ferner's point, and that is sometimes these kids, they just rebound so well. And I don't know if it's their youth or their sort of lack of knowing how close to the brink they came or something along those lines. How is she doing? Have you seen her back since the halo was set?
I have not seen her back. So she's been following up over in orthopedics, going in fairly frequently and being seen and adjusted. And but we have not seen the family back in about 3 months.
Okay.
By adjusted, do you mean they put in growing rods, or did they just put regular rods in?
Regular rods, because she's 12. She's still
that's what I thought.
Yeah.
I just heard the adjusted and it made me question. And so that was a similar question from the audience. How many months is this child currently post-surgery?
From which one? So
good question. Both the MPNST and the spine.
So spine, she is about 2 months out, because she had the one where they went in and did some of the procedures to loosen all the ligaments, put the halo on, and then another month. So she's about 3 months out from the original and the halo, and 2 months out from the rods. The original resection of the mass was So she's now, oh my goodness, this year is flying by. She's about 7 months out from that.
Mm-hmm. And what's her surveillance plan?
Right now, she had the one follow-up PET scan, and then if I were going to do it, I would do another one. But then the question is, now she's got rods, and trying to figure out the PET part should be okay, but the CT and trying to figure out what kind of artifact we're going to get all the way through. So,
I mean, this is going to be a challenge moving forward, clearly because of the rod that she so desperately needed. But I think surveillance will be important. So what is the plan for that?
My plan would be do it again in these 3 month intervals, kind of like how we do optic gliomas, and kind of see where she's at, make sure that there really isn't anything growing back. I'm open to suggestions for other plans.
Panelists?
Tricky. I think I'd do what you're doing.
Well, that makes me feel really smart. Thank you.
And
I'm not sure
that a super important question from the audience too. Was social work engaged given the many psychosocial issues?
So that was one of my brilliant, well, I'm not brilliant, but what I finally got was a social worker for my clinic. So she has been involved with this family as well. And then once you're in oncology, all the oncology clinics always come with a social worker. So they now are getting wraparound social work care like you would not believe, which is probably more important than anything I'm doing.
Yeah. And one thank you to the panel. And one last question, was radiation deferred because of the patient circumstances, or was it deferred generally?
So generally it was deferred amongst oncology, radiation oncology, and our neurosurgeons. So there were multiple opinions, as there were on this panel. At this juncture, they felt just doing the follow-up surveillance and also in discussion with the family that this is kind of the best path forward.
Excellent.
Nikki,
I want to thank the panel, Drs. Viscaccio, Klesse, and Ferner, for their participation and lively commentary, and to Dr. Trepane for guiding us through an excellent case that has a lot of different factors going on to really think about and challenge us, and to the excellent questions from the audience, which really brought it away from feeling so far away from one another, and it was very helpful. So on this note, I will close off the case portion of our clinical care symposium. And again, thank you to everybody for participating in this opening symposium. And I invite you to go have breakfast, lunch, or tea, depending on which part of the world you come from. And we will see you again in a short time.